My name is Ashley Vo. I'm the director of the Transplant Immunotherapy Program at Cedars-Sinai Medical Center. I currently hold a academic appointment at UCLA as a professor of pediatrics. I was asked to give you a summary of this current paper that was recently published in AJT last month on assessment of tocilizumab as a potential treatment for chronic antibody rejection in highly sensitized patients who develop TG. And this paper is considered a seminal paper for our center, primarily because we have patients who have antibody-mediated rejection that fail our standard of care treatment, which included pheresis, IVIG, and rituximab. They progress to graft loss with that treatment. However, we were able to use a novel agent, which is tocilizumab, which is an interleukin-6 receptor blocker. This medication is able to demonstrate a prevention of worsening of allograft outcome, but also maintain the GFR out to 6 years that these patients were studied in. At 6 years, as you know, 50% of the patients who develop TG early on lose their graft within a year or two. But these patients who receive tocilizumab as a rescue therapy for treatment of antibody-mediated rejection and chronic antibody-mediated rejections, at 6 years, the graft survival was 80% and patient survival was 91%. So not only these patients did not lose their graft, but they maintained their graft 80% at 6 years. And if you look at the biopsies of these patients who we were able to rebiopsy, there were improvement in their inflammation as well as the C4D score pre and post treatment. So this therapy is now considered at our center as the treatment of choice for patients who have chronic antibody-mediated rejection with TG on their biopsy.
All right, let's do some questions. What's the ideal duration of therapy for tocilizumab?
As the number of patients that we have treated increase, we do feel that it is at least monthly times 6 months. And if you continue to see presence of DSA or no change in the DSA strength, then you should continue at least for another 6 months to equal 12 months. And then after that, you can reassess. But we have had patients who have required as long as at least 3 rounds of tocilizumab in order to get rid of their antibodies.
What are some practical considerations for the pharmacist recommending tocilizumab?
You do need to have labs checked prior to the tocilizumab. So if a patient is coming today to get the infusion in preparation for the next month's infusion, 2 weeks after today's infusion, they would need to get their labs, CBC with differential, a BMP with LFTs. So we monitor for we look at their white count, we look at their platelet, we look at their neutrophil count, as well as their LFTs, just to make sure that if there were any elevation in the LFTs, we look to see how high is it above the normal. If there's low platelet or low white count, we look to see what is the trend, because we will hold the dose if the white count is less than 3,000 or platelet less than 100,000. And instead of saying, okay, well, you're not going to get the infusion for next month, what we would say is let's repeat labs 2 weeks after. And then if the labs looks good, then we may need to increase the duration, meaning instead of every 4 weeks, we may need to go every 6 weeks or every 8 weeks, but not stop it altogether.
All right, last question. What's next for tocilizumab?
We actually use tocilizumab for desensitization, and actually it works very well in the highly sensitized patients who are difficult to desensitize. We know at our center we can transplant about 60% of the patients with our standard desensitization, IVIG, rituximab with or without pheresis. But there are 40% of the patients who are difficult to desensitize, and we find that we could get them to transplant with tocilizumab. So it can be used for desensitization, it can be used for lowering donor-specific antibody after an acute antibody-mediated rejection, or for chronic ABMR based on this paper.
Hey, Transplant Pharmacy COP, Tim Horwedel, one of your executive committee members, thanking first Ashley Vo for participating in this interview, and secondly, thanking you for watching. Please share with us your ideas about future segments or future articles that we can feature, and we'd love to have you involved. If you're interested in being a part of this committee, please reach out to myself at timothy.horwedel@bjc.org. Thank you.